We have our facilitator here present, pharmacist Funke Ogunyemi, a pharmacist practicing as a hospital pharmacist in the prestigious Lagos State University Teaching Hospital. And she works in the ARV Clinic. She is a master's degree holder from the prestigious University of Lagos. You're welcome, ma. So this juncture, looking at the epidemic and this year's theme, end inequalities, end is an end epidemic. So we are looking at the roles of young pharmacists, knowing that the community pharmacy is usually the first port of call when most persons fall ill. So what we are going to do as young pharmacists to support the end of inequality, end of AIDS, end of epidemic. And at this juncture, I will give our facilitator the floor to enlighten us as we listen carefully this evening. Thank you very much, ma'am. You have the floor, ma'am.
Yeah. So thank you for having me. I'm happy to be here, and I'm happy to impart knowledge with every of my audience. Good evening, everybody. Please, can you share the slides? Something so, can you share your slides?
Okay, yeah, I'm working on that.
Okay. My job is very straightforward and simple. I'll be discussing the roles of young pharmacists towards the eradication of HIV/AIDS. Yeah, before I start at this junction, I would like everybody to mute their mics, please, so I don't get distracted. Please, can you mute your mics? I can see here some background noise. Yeah, but irrespective, I'll move on. So, what is expected of us as pharmacists generally in HIV care? It's not far-fetched. You know, the pharmacist involvement in HIV therapy or in caring or ending the epidemic is pretty straightforward. We are the first point of call to every client. So you have someone who got exposed to unprotected sex. They come into community pharmacy, for example, they'll come for emergency contraceptive, they want Postinol, they want even more. You understand? Yeah. So if you see a client walking in, you know, someone that's been practicing that for quite some time, at one of the visits, the pharmacist has the opportunity or privilege to, you know, engage this particular person, you know, to exactly know, you know, what their lifestyle is about in a very friendly manner. Oh, madam, what do you do for a living? Now, the reason why this is important is you do not know if that person is a commercial sex worker or something. You know, you may also advise them to get tested for HIV because they may tell you they're using protected sex and they may not eventually or at all be using protective sex or engaging in protective sex. So our role as pharmacists is very key and, you know, and very engaging because we are the ones people see first. People don't want to go to the hospital. They don't want to see the doctor because the hospital queues are too much. The protocols are there. You know, if you don't know anybody in the hospital, you may be there for a whole day. So people rather come to the pharmacist, you know, to tell you their care. So after this training, what I expect us to do is to know more about what our involvement in care for HIV service are. So I'll start, I won't want to bore us with what HIV is, human immunodeficiency virus, you know, how it is transmitted. We all know that HIV is transmitted via unprotected cells, sharing of sharp objects. It can also be transferred from mother to child. You know, if a mother is not well covered in HIV care, if she's not on ART already, and she gets pregnant, she has high viremia, high viral load. You understand, viral load is the number of virus that is in 1 ml of the blood sample. You know, if the woman is not well covered, the baby is at risk of contacting the HIV virus. Now, before I go on, I would like to say that HIV, unlike what people think that, oh, it's through the sex only. Yeah, some people get it by even sharing sharp objects. All of us at one point or other, we go to the barber shop. For women, for ladies, we go to hairdressing salons, we go to make our hair. Some of these equipment that are being used are not proper, if they are not properly sterilized, God forbid, when we contact HIV, through that way. And one of the reasons why people keep being stigmatized, or the fear of telling people about their status, is because of stigmatization. Because the first thing people think about is that, oh, this person has HIV, oh, she must be promiscuous, oh, this person must have many sexual partners, this person must really have a very bad history for her to come in contact with HIV. I am privileged to been in HIV care for over 15 years. So, I can tell you categorically that there are people who are just victims of circumstances. For example, you have a child who was born to parents of HIV, who has HIV. This adolescent, for example, has no history, of being promiscuous at all. The child does, nobody say, oh, God, I want to come to this family. She was just born into that family. She just found herself there, or he just found himself there, and he has to leave. So one of the things we need to remember is that stigmatization is real. You may not know that you are oozing out that vibe to the person you're talking to. So when the person finds that if you are afraid to talk to him or to relate with him, or your eyebrow is looking a little somehow, the person will not be able to give you enough information as a community pharmacist, for example. So I walk into a pharmacy and I want to talk to you about my status. Oh, I noticed this rash. I don't want to go to the hospital. What can I use? If you are not well equipped, or if you do not know what to do, you will not be able to know if this is a drug reaction, or this is a fungal infection, or this is an opportunistic infection that is surfacing. So basically, the most important thing for us is, number one, we must to treat an HIV patient, you must not stigmatize. Whether the person is key population, by key population, I mean lesbian, men sleeping with men, you have gay, you have bisexual, you have transgenders. They are already, in high numbers in Nigeria as we speak. I'm sure a lot of us have seen them before at one point in time or another. So one of the key things we need to understand to actually come in contact with this client, for them to gain your confidence, is one thing for them to walk in and buy the routine drugs. But the moment they open up to you, they expect a higher level of understanding, of confidentiality with them. So not to bore you all, I will start with classes of ART. So what are the goals of ART? Why are people using drugs? Do you understand? Why are people using drugs in the first place? So basically, we want the client to maximally and durably suppress the plasma HIV RNA. By this, I mean that's the want to achieve viral suppression. One of the goals is achieve viral suppression. We want to restore and preserve the immunologic function. These are under goal. This is also known as the immunologic function. We want to also reduce the HIV. Can you all hear me, please? Yeah, so
yes, I can.
Yeah, thank you. So also want to do an epidemiology goal, which is by reducing the HIV-associated morbidity. I want to prolong the duration of survival. We also want to prevent HIV transmission. This is also known as, so we have the clinical goal, we have the immunological goal, we have the HIV, we have the epidemiological goal, that's number 3. And they also want to reduce preventing from one person to another. Now, we also recommend that combinations of a minimum of 3 different drugs with 2 different classes is what we use now. That's what we are recommending. That is the new, recommendation for HIV treatment. So in pharmacy school, we're taught that the highly active antiretroviral therapy, the HART, whereby you have the 2 non-reverse transcriptase inhibitors combined with 1 nucleoside reverse transcriptase inhibitor as first line are our goals. For now, HIV medicine has has improved. You know, it keeps evolving day after day with new researches ongoing. So the future is brighter for the HIV patient now. So now remember that we want to, as much as possible, reduce pill burden. So thereby now what we are doing now is we want someone to be on just one tablet that contains two different classes of drugs. So at this point, one of our most important drugs that we are pushing right now is tenofovir, lamivudine, dolutegravir. And now I will cite an example of the class that they belong to. So tenofovir and lamivudine, they belong to the nucleoside reverse transcriptase inhibitors, and we have dolutegravir. It also is on the class of integrase transfer, strand transfer inhibitors. So that's an example of three drugs containing two different classes. So the nucleoside reverse transcriptase inhibitors, they are proven over the years to be tough, to be effective, and you know they have very high viral suppression. So you can imagine, yeah, in many years ago, HIV viral suppression is achieved by 6 months. So someone comes with a viral load of 2 million, for example. We expect viral suppression in 6 months. So we tell you, let's check back in 6 months. But with dolutegravir, the new integrase strand transfer inhibitor, dolutegravir actually suppresses virus in 2 weeks. You know, it's amazing, you know, and that's why the drugs for the HIV patient keeps evolving, it keeps changing. And when we counsel our patients, we keep telling them it's good for you to move with the flow, because the old drugs are tired, you know, resistance has developed with the old drugs, and the newer drugs have better resistance to and effectiveness to HIV virus. So the ARVs are classified according to their actions. Each class targets different steps in the viral life cycle. So I'll just go through to the classes and the examples. So we have, sorry. Yeah, so I have the nucleoside or nucleotide reverse transcriptase inhibitor. So the tenofovir is the only nucleotide reverse transcriptase inhibitor available. You know, so the others, the abacavir, the lamivudine, you know, the stavudine, the didanosine, and the like, they are all nucleoside reverse transcriptase inhibitors. You know, for the stavudines, they have been discontinued because of their severe side effects that they come with lipodystrophy, they come with transfer of fat from one place to another. You know, they come with people having transfer of fat from their legs, you know, to their buttocks, for example, to their thighs. So you see someone that looks healthy, but when they stand up upright, you see a lot of veins. You see a lot of veins. You also see their legs are very skinny. So people started complaining, started losing confidence in themselves, and thereby leading to the discontinuation of those drugs. Then for the non-nucleoside reverse transcriptase inhibitors, examples are efavirenz, you know, which is rarely used. You know, we still use them for some of our patients who do not tolerate dolutegravir. Then we use nevirapine mainly for prevention of post after delivery prevention for babies, newborn, to further boost their protection from their mother who is HIV positive. Then dolutegravir is from the next class, HIV integrase inhibitor. We call them strand transfer inhibitors, and their level of reducing the virus is tremendous. You know, outside this class, they have been in use for third line. So like we have the ratigrapar, it's been in use for so long, but now with the new invention of dolutegravir, you know, I'm bringing it to first line. You can imagine it's going to help people not to even progress to second line in the first place, because its rate of viral activity is really high. Then for the second line, we have the protease inhibitors. Some of us must have seen that. We have the lopinavir, atezanavir, and the second generation is darunavir for the PIs. Then we have the entry inhibitors, maraviroc and enfuvatide. These are usually they are injectables. and they are discouraged in usage because of people keep injecting themselves, and they complain of reddening of the injection sites and all that. So we have a patient who used to use that, and the patient couldn't tolerate it. She used to come back complaining that the injection is too strong for her, and then we move that to something else. So we have more kinetic enhancers. We have the ritonavir, which is used to boost the other PIs, and we have the cobicistat, which may not necessarily do much, but just allow the other antiretroviral, to be present, in the body, in the plasma, for them to operate, better and longer. So we can't talk about ending the HIV pandemic without talking about the United Nations its goal. We have the fast track target that we said was goal 1990 by 2020, but has been long reviewed by the last International AIDS Society conference, and now we have moved it to goal 95, which this simply means is that we expect that 95% of everyone who has HIV are aware of their HIV status. So people who are HIV, 95% of those who have HIV are aware of their HIV status. Then 95% of these people who are aware of their status have started their HIV drugs. They are on antiretroviral therapy. And we expect that 95% of this set who have also started antiretroviral therapy are also virologically suppressed. So we expect that by 2030, 95% of everyone who has HIV is already aware of the status. 95% of them have started their antiretrovirals, and 95% of this set of people are also virologically suppressed. So we expect that by 2030, new infections should have dropped from 500,000 to 200,000. And of course, we expect zero discrimination. Discrimination has been a tall goal, for the trick of care in Africa for now. It's been a lot of challenge. Discrimination is ongoing. Discrimination is one of the things which has made Nigeria or Africa in general not to progress in the HIV care. People don't want to come to the hospital center or facilities to come and seek help because they feel the nurse may be their neighbor, their relative, they can see somebody that they know and all that. So now, what can young pharmacists do? Pharmacists are very relevant, irrespective of the vibe we get from the health sector. We should not relent in our support for HIV clients. Pharmacists are accessible healthcare providers who practice in settings that are conducive to delivering HIV treatment and prevention services. So because the pharmacists are always accessible healthcare providers, people will always walk in to ask one or two questions, and by the time this patient or client walks in to your pharmacy and they're asking you these questions, you can actually ask further questions, which can take you to, oh, do you know HIV status? Oh, I can get you a test kit. You can do your self-treatment at home. A whole lot of things can evolve because the pharmacy are positioned in a situation whereby people can walk in, even when the hospital centers or facilities, healthcare centers are not open. The pharmacies usually provide a non-stigmatizing and acceptable venue to receive health services and have more flexible business hours than the health clinics. So the pharmacist involvement in the care of HIV positive patients has been associated with improved patient outcomes, including enhanced adherence, reduced pill burden, dosing frequencies, greater increase in CD4 cell count, higher rate of viral suppression, and decreases in medication errors. So now if a client walks into your pharmacy and they have a challenge, and if over time they have built confidence in talking to you, and they walk in and they have challenges, with their drugs, the pharmacist is always there to encourage them. The pharmacist is not just there to encourage them to check out for comorbidities. So what other drugs are you taking? Is there a drug interaction with these drugs? Okay, Can we separate the timing of these drugs? So you can always walk around what is available to your clients, because now the HIV patients know that their drugs are taken routinely at a particular time. So I'll give an example. So you have a patient when we're taking efavirenz. Efavirenz is advised to be taken at night. So efavirenz is taken at night, and you have this man who is a bus driver. So he drives luxurious buses to the east. Are you going to advise him to take efavirenz at night? No. So because there's no hard and fast rule to the routine timing. So you may want to do it per time, per individual. So you may also want to adjust individual, you may want to add individuality to taking their regimens. So that patient can talk to a fellow patient and say, oh, you take yours at night, I take mine in the morning. The other patient may say, oh no, you're taking it wrongly. The timing is at night. But I always tell people like that remember that your own timing is only specific for you. You should not tell somebody else to take theirs in the morning, because it's going to affect their work. I had a patient who says she wants to take Amudro in the morning, like the man, and whenever she gets to work, she just forgets whatever boss asked her to do. She's a PA. So, okay, remind me, I have a meeting for 10 o'clock, and she has just forgotten. And I told her, your drug is supposed to be taken at night. You cannot, be like the other man who spends his whole night on the road. He takes a efavirenz, he has drowsy effects, he will sleep. So but he takes it in the morning, he can spend his whole morning sleeping, and at night when he's on the road, his eyes are wide open, and he can function well as an individual. Being HIV positive shouldn't rob them of their daily life. So the pharmacist and the pharmacist can actually play an important role in HIV care, including dispensing ARVs, providing HIV screening, close linkage to care. Like I said earlier, I said that, I've been privileged. I have an HIV blog on Instagram, on Twitter, and Facebook, HIV Chronicles, and I have been able to relate to people. One of the burdens I had was that I found that a whole lot of people were a lot of people were hiding. They didn't know, they knew their status, but also there was a gap between knowing their status and also coming on board to the hospital. So they're HIV positive, they're dying in silence, they're at home without taking drugs. So I just needed to break even, and I created that HIV Chronicles on Instagram. And believe you me, the responses I've been getting, shows that there's actually a huge gap. People on social media, people are looking for who to talk to. You have people who just want to access care, but don't want to come out in the open to access care. So, by the time the pharmacists, so by the time the pharmacists are equipped enough, we can always refer people. Okay, where do you live? Okay, you live at Shomoli. Okay, go to this pharmacy. You're going to meet a pharmacist who is going to get these drugs for you, who's going to, you understand, link you to care. So what I do basically is linking people to care. So if you contact me, you're in Kano, you have been positive for quite a bit, I will just link you to the Kano General Hospital. Of course, because I have a long-time experience, so I have friends all over. So I'll just call my colleagues on the other side. Oh, I'm sending someone to you. Please, can you help me keep it confidential? This person doesn't want to go public. Can you help? And over the years, I've enrolled about 20 people, in HIV Chronicles, and that keeps giving me joy, knowing that people who could not have accessed care have actually been able to access care, at no cost. So it's just a passion for me, So I just want people as much as possible to access care. So pharmacists can, you can help people get their drugs. You can help them. You can send them to get HIV screening done. You can link them to care like I did. I've done in the East. I've done in the North. You understand? So, I've linked someone to care in Ado Ekiti, and all that. And you also have people who are, we call them, what's the name now? So we have people who are married to people who are not positive, so they also need to be taken care of. And we have, for those people, we prescribe pre-exposure prophylaxis. Now, pre-exposure prophylaxis is like you are prepared to sleep with someone who has HIV. So you are aware of your partner status, and you want to go ahead and sleep with that person, maybe for making babies, for those who are discordant couples, for making babies, or for those for the fun of it. So people date people who are HIV positive and they are aware, and they actually want to go ahead and still date such people. So basically, those ones are actually for those purpose. So pre-exposure prophylaxis is actually for those who are dating those who are positive. And the drug that we prescribe for them is actually tenofovir emtricitabine. It's called Truvada. But in Africa, what we use is tenofovir and lamivudine. You know, Lagos State recently, about 2 years ago, they opened a one-stop shop. The one-stop shop is located in Lagos, in Agege. We have one in Pharm Avenue, in Mushin, you know, in several centers, and all they cater for are the key population: the gay, bisexual, lesbian, the commercial sex workers, and people who are gay and lesbians. So what they do to them is that they give you free drugs for your pre-exposure prophylaxis, but they encourage you to bring your partner on board. And one of the things that happen to all these key populations are they don't usually have one partner at all. They don't have one partner, they have multiple sexual partners. So in other words, you encourage them to bring all their partners on board. Remember, one of our goals is to reduce the level of transmission to new partners. So in our mind, we want you not just to assess pre-exposure prophylaxis, but we want you to also bring your partner for testing. Pre-exposure prophylaxis are only for HIV negative individuals. So the person walks in, oh, I want to do HIV positive, I want to do HIV test. Person is negative, then the questioning begins. We fill a form, and then we know, then we're able to tell, okay, you're gay, you're lesbians, even though we don't say that to their faces. We know from the interview, you just know that. And then that will also channel your conversation to the right, place. So then you can talk about pre-exposure prophylaxis. So basically, our role as pharmacists is most importantly done if capacity is built. So someone walks into your pharmacy and is telling you about HIV drugs. He's telling you about opportunistic infections. If your capacity is not built, if your knowledge of HIV management is not heightened or improved or updated, the person may be lost in the management to profile to the client. So we expect that as pharmacists, one of the most important things you can do, in fact, the reason why you can talk to a doctor or refer a client to a doctor is if even you have built capacity. It doesn't cost much. Internet is on for every one of us. We have data to check new treatment guidelines, for HIV management, you understand. So basically, capacity has to be built. We have to update the knowledge of HIV management using the most recent treatment guideline available in the country and globally. Is actually key in making an impact as a pharmacist. So basically, my next slide is just showing us the most recent improved guideline by the World Health Organization in HIV prevention, testing, treatment, the service delivery, and monitoring. So this guideline is all encompassing. It talks about everything. You need to know how to do pre-exposure prophylaxis, how to do post-exposure prophylaxis, how to do testing. Initially, I remember many years ago, when people test for HIV, they actually wait for a particular level of CD4 count before HIV treatment is started. So they wait for 250 CD4 count before the woman can start HIV treatment. They wait for the CD4 count to become 400 before the man can start HIV. But the most recent treatment guidelines say once you are HIV, once you test, then you start treatment immediately. So we're not waiting for CD4 count. The reason why we're taking CD4 count is to be able to differentiate those who have acute HIV disease, AHD, is for us to know whether to check for other opportunistic infections that can also hinder the activity of the antiretroviral therapy. So someone comes in and the HIV and the CD4 count is 20, or is 2, or is 0, or is 1. That person has a higher risk of coming down with TB of coming down with cryptococcal meningitis, of coming down with pneumocystic carina pneumonia. The person has a greater chance of coming down with all that, So the reason, so what we are doing now is that once you're positive for HIV, you just test it for TB, you test that every other thing is in place, and then you start your treatment. So once somebody is positive for HIV, treatment commences immediately. So one of the things, so after you have built capacity, next thing is diagnosis. Because the pharmacy is accessible, and like I said earlier, you ensure that your pharmacy or where you operate from is non-stigmatizing. So what that means is that so you're not attending to those kind of clients in an open room. So you have a room for the pharmacists where they can actually confide in you. They can cry if they want to when they are burdened with their treatment or they are tired with their treatment, So there's accessibility and the environment is non-stigmatizing. The pharmacy may actually serve as an important testing venue for people who have never been tested for HIV and or for those who have even come for the confirmation of their status. So, I had someone who contacted me via my Instagram handle saying that she got a job and and they told her she was HIV positive. She really cried bitterly and said she didn't know how she came about that and all that. I just allowed her and I asked her to see me. So I think we fixed an appointment. We fixed an appointment and then we we fixed an appointment and she came. By the time she came, we did another test for her at our center and she was HIV negative, So some people actually come to the pharmacy because they have had a previous positive test. They want a reconfirmation. And thank God for advancement in HIV testing. Now people can do HIV testing by using a swab stick around their mouth, in their oral, just swab it and then they put it in and the test result comes out in a few minutes afterwards, telling them they're HIV positive or negative. Remember that when people come to you that they are HIV positive, you need a second confirmed result in a typical center. So you can refer them to a health facility to go and get tested, So you can link them also to other pharmacists, you understand, and then treatments can occur. But remember that if someone tests positive and they come to you, allow them to tell you exactly how they feel, and then from there, from how they feel, the pharmacy intervention can always come in. Some people are not ready to start treatment immediately. Some people want to go and think about it. So it's not, oh, you have to start a treatment now. No. Some people need to ruminate over that before they actually agree to taking their drugs. Then the pharmacist can also help increase the United 895-95-95 goal by promoting self-test kit to clients suspected to be HIV. So you have a patient coming in routinely to buy the contraceptive, the postinatal, and the like. You can just get talking, never stigmatize anyone, don't know their journey in life. So basically, even if they're commercial sex workers, at most what you can prefer is an HIV test, just for their well-being, all that. So feedback from such clients to be sought for further care plan, like referral to the nearest health facility for a follow-up. So International AIDS Society meeting instructed that everybody should try to make life easy for less burden for the HIV survivor or HIV patient. So it was said that differentiated services or differentiated care models, should be approved globally. And Nigeria, of course, came on board in 2016, and it was said that in order to reduce the patient waiting time for patients who are stable at the healthcare facilities, they need to access their drugs from other places apart from the healthcare facility. So how does this work? So you have a lot of patients waiting in the hospital, patient waiting time has increased. Remember that these patients have their regular they have their regular lifestyle. They have to go to work. They have to do other things, you know. So basically, we need them to also have their life, you know, to continue and not hindered because they're HIV positive. So thereby, we said that we should create other avenues where they can, you know, get their drugs. And pharmacists were quick to come on board. Thank God for that. Now it's been approved among, you have the out of facility individual models, which allows community pharmacies to actually sell as a drug pickup center. So if you have a pharmacy and you actually want to come on board and your pharmacy is strategically located, because we have, for now, we have over 500 from community pharmacies who are helping in the HIV patients to assess their treatment in their pharmacies. And the good thing is that they actually get paid. So every pharmacist that sees an HIV patient, we pay you, you know, for helping to, you know, reduce the burden of HIV in the lives of these patients and Nigeria as a whole. So the role of a community pharmacy, what we expect is that the community pharmacists will follow up on the clients on the adherence to their drugs. So they give them multi-month number of drugs. So they give from 3 months to 6 months, you know. So this patient only now come to the health facility maybe once or twice a year when they have to see a doctor. The only reason why you send them back to the hospital is when you feel they are smart, they're trying to be smart, they don't want to go and see the doctor, they only want to come and collect a refill of their drugs. That is when they send them back to the hospitals. So one of the things that the pharmacists can also do is that you can actually manage those clients for their comorbidities. So this patient, oh, what other drugs are you using? You know, I have blood pressure, hypertension. Oh, let me see your drugs. The pharmacist can actually help in reviewing those drugs. They can actually help in spacing the timing for those drugs to avoid drug-drug interaction, drug-food interaction, even lifestyle. You know, it can also help them to promote their lifestyle. And remember, those drugs come with a pay. So they get their HIV drugs for free and they buy the you refer back to the health facility if this client has a detectable viral load, which is a viral load that is 1,000 copies in 1 ml of their drugs. So routinely, we, the pharmacists in the health sector, in the health facilities, we interact with our pharmacies outside. You know, oh, this patient that was here, the viral load is out. This is the result. Kindly send this one back. He's not adhering properly to his routine medications. So rather than the patient coming for refill, the pharmacist just refers them back to the health facilities so that we can do proper monitoring. Now, there are criteria used in devolving these clients to community pharmacies. It includes the person must be an adult, 18 years and older. The person must have been at least 1 year on their antiretroviral therapy in the health facility. We do not want people who develop TB in their early HIV treatment commencement to be devolved and they will lose track of their improvement. So we want to monitor it for a whole year before we send it to the community pharmacy. The person must have good understanding of lifelong adherence to ART, and then they are also adherent to their treatments. The person must have had no AGLs that require regular monitoring. The person's evidence of treatment success must be obvious. So the person must have a virus load and showing suppression in the last 12 months. Person must not be on TB treatment or other medical conditions that require regular clinical consultations like renal impairment, you know, liver infections in any way. So any comorbidity, we are not going to refer to the community pharmacy. Not currently pregnant or breastfeeding. We want our pregnant women to be well monitored and want them to remain in the healthcare facility. And then to devolve a patient, you must get their consent. Do you want to go to Shomolu? Do you want to go to your neighborhood? Some people decline. Some don't want to go to their neighborhood. Some don't want, they think people can know their secrets. So some want to remain in the health sector. But their consent before they get devolved to the community pharmacy is very key. The pharmacists can assist with national efforts to end the HIV epidemic by delivering a range of HIV prevention care and treatments. And like I said earlier, able to dispense the ART, HIV screening, selling the idea to your clients who come in, adherence counseling for those who are already on treatment, medication therapy management, because of extended hours of operation, and because the pharmacies are always accessible, and they're affected by, for those who are affected by HIV, and then because, of course, the pharmacy should not be a stigmatizing atmosphere place, they can also play a pivotal role in the eradication initiative by increasing access to services for people living with HIV and people at risk of infection at large. Thank you.
Thank you very much, Ma, for the wonderful presentation. Please, if you have a question, just raise your hand. And I want to greet some of our leaders in the house. We have pharmacist Muyiwa Olagunju, a former PSN-YPG national chairman. You're welcome, sir. We have pharmacist Nkpasi Usoro, the current national vice chairman, PSN-YPG. Pharmacist Cindy Ozoloha, the current public relations officer. Pharmacist TJC Foloronsho, the former secretary of PSN-YPG. Pharmacist Nura Adolahi. Okay, before we continue with take people's question, Ma, please, can you hear me?
Yes, I can.
You said something that when someone is diagnosed, you said initially it was after diagnosis, then you can check the viral load to know if they are going to start person on medication, on therapy. But at the recent guideline states, as you diagnose the person, you start the treatment immediately. And you also said that you allow these patients to decide if they are going to start treatment immediately. And knowing that since the person tested positive and you are not able to check maybe the CD4 or viral load, and you want the person to decide if he or she will start the treatment and when he or she will start the treatment. If the person happens to leave without coming back, is this person not a public health, like a constituting risk to other persons? Because they can go and they will decide not to come back and just die in their silence. So how do you manage this situation? Thank you.
Yeah, so basically for people who, for the test and start, so in the community pharmacy, that may be a bit difficult. So basically what our advice is that in the community pharmacy, if someone comes to you and they're able to sell the idea that, oh, can you do your HIV test, and the person agrees, definitely the person, number one, the person will likely come back to tell you the status. Oh, sir, I found out that it was positive. What is next? Now, by the time they come back to you, and how they live is also key. Okay, so you tell the person, the first thing you say is that HIV is no death sentence. Because I can assure you that 90% of people who find they have HIV are usually suicidal. Some feel life has ended and there's nothing they can do about it. So once they come in like that, you just tell them HIV is no death sentence. There are drugs, these drugs are accessible, they are free, at no cost. All you need to do is just come and I will get you, But before I do that, I will need to confirm it again. I'll link you to a colleague of mine who will follow up with you on that. Now a call is made, I think last week we had someone like that, referred from someone to us from Shomolu local government. Someone walks into the pharmacy and she realized that this person was HIV positive. The lady didn't want to come to the facility, So but we were able to convince her at that phone call. So not allowing them to leave is also important, and also getting their contact. And I tell you, get their contact, you are telling them that, oh, can I flash your number? So you get their number, you talk to them. But really, the almost is actually on that person to decide, just like you tell them they are positive, to get on treatment. I've spoken to quite a number of people who still decline treatment. There's really nothing you can do other than to counsel. You counsel people, so it's the confidence that they have in you that will determine they are going to come back or not. If your first reaction is, oh my goodness, they're HIV positive, if you yourself look dazed or you look like, oh wow, the person will say, oh, so if this person already is looking like my life has ended, so what am I supposed to think? So no matter how huge or surprised or how bad the situation is, I just tell you that HIV is no death sentence, because you're living longer in life or achieving whatever you aspire to become is dependent on how early you get on treatment. So you can actually choose to walk away, and after a few months, the whole world knows you have HIV, because HIV is only hidden if you can walk by yourself to the pharmacy and pick up your drug. The moment you cannot talk, the moment you are too weak to even walk, then the people you are sending on those errands, you'll be inquisitive enough to know what you're taking. So, so by the time you tell these people the real truth, they'll make the decision. Now, so like I said, it is test and start, like you rightly said, but we always check for their CD4 count. Some people, even though they have HIV now, they will not start treatment until 2 weeks after they have commenced their treatment on TB. Some come with TB diagnosis as well. So when people test positive, wherever they are testing positive, either from a private laboratory, either from using the mouth swab, or whichever routine they have done their HIV test, there is supposed to be a second test by a health facility. The reason is because the test equipment are highly sensitive and we'll pick it. I told you someone contacted me, said when she got the job, the test she did, test was positive. By the time she came for a second follow-up test at the facility, the test was negative. And she has come three months after and is still negative. So you can imagine if someone was quick to get her on treatment. So a second test is very key. You won't just do a second test, you also screen for other opportunistic infections that comes with HIV. And that will guide us. So if you put the ART before the TB treatment, the TB in the system will jeopardize the effect of the HIV treatment. So the TB treatment has to come 2 weeks ahead. The person will just start, then, oh, I'm dying. Now wait, give me, in fact, some people beg you for the drugs. They say this drug will save my life. I'll tell them the drug will not save your life as long as you do not take care of this TB. The TB now is priority, So other opportunistic infections as well, they're also important. We check them, we screen for them, and then that way we are able to make an informed decision. So we can tell you that, oh, test and start, yes. But remember that we have crossed all our T's, we have dotted all our I's. So at the community level, when people test positive, you counsel them and refer them for a follow-up test. So you can even tell them, oh, go for a second test, let's just confirm. If people don't want to come to the health facility because there's no one for them to relate with. So if you tell someone that, oh, look, I mind the lady that I told to come. She was eager to come because she knew when she just gets to Lutz Gate, she will call me. Oh, ma, I'm here now. Where do I come to? So immediately she came. She didn't pay me. I only referred her for test to see the counselor, and she was tested, and the test came out negative. So unlike if she was just walking into the hospital and she was not assessed, doesn't know anybody, doesn't know her left from her right, then there's a dilemma there. So she may not be willing to come. So that's just one of the gaps. So as pharmacists, we work together as a team to ensure that we're able to refer people to centers where the person that we are referring is attended to promptly, and life of that person will not also, or time will not be jeopardized. Hope I've answered your question.
Yes, thank you very much, ma. There is a question by Pharmacist Olagunju Muyiwa on the chat box.
Okay. Yes. So yeah, there are available trainings for pharmacists on HIV. So you have even though some are not free, you have the University of Washington. I've had about 8 or 9 of their course. I've run most of their certificate courses. They have one for HIV training. So one can always use the opportunity to always sharpen one's skills in HIV management. So University of Washington, I'm sure they do trainings on that. I can then we can also go to United Nations. WHO also has some training slides on their center. So basically that way people can go. I'm sure of University of Washington. So you can chat with me afterwards. I can link you up to check when their next training is coming up so that everybody here can also learn on the subject matter.
Okay, thank you very much, Ma. It's a wonderful
Welcome.
session with you, and we hope to reach out again subsequently for further discussions on this. And we also want to we will request for your Instagram handle so that young pharmacists too can follow that particular one you have
Okay,
that
so
we
I'll just,
use to reach out to these patients
yeah, I'm already,
because we are keen.
yeah,
Maybe about
yeah, I just typed it in now. So it's at HIV Chronicles on Facebook, on Instagram, on so it's there. So I put on for everyone to see is HIV Chronicles. So basically, what I do is, I link people to care. I counsel people. A lot of people are going through a whole lot behind social media. People are going through a lot. People want to start treatment for Malaysia. They're stranded. People are in Nigeria during the COVID session. People were stranded the COVID time. People came to Nigeria for visit. They are on their ART treatment. They couldn't access treatment. So what I was doing at that time was just linking them to treatment centers around their places, getting dispatch riders to get them their drugs, at no cost. I've also been able, I have 2 couples from HIV Chronicles who I know the groom with HIV positive partner and the wife now, she was accessing care from um, Kaduna State. She reached out to me and I linked them up together and they are married now. So basically, HIV Chronicles